All right, let's review some endocrinology. Men 1 has pituitary, pancreas, parathyroid. Men 2A, they both share pheo and thyroid. However, 2A also has parathyroid. 2B has mucocutaneous marfanoid. TSH in pregnancy. So if you have normal thyroid function, then you'll have enough reserves so that you'll be euthyroid. But if you're hypothyroid, then all the estrogen production and beta-HCG will actually increase the thyroid binding globulin, which will decrease your free T4 because more of your T4 will be bound. So you'll need to increase the levothyroxine if you have baseline hypothyroidism. So osteomalacia will be from a malabsorption or an excess amount of secretion due to vitamin D deficiency, renal tubular acidosis type 2, which wastes calcium, or decrease in calcium intake. That leads to bone pain, muscular pain, fractures, pseudofractures on X-ray, thin cortex, and concave vertebral bodies. And that's compared to other pathological fractures like from osteoporosis, lytic Metz lesions, like breast, multiple myeloma, renal disease, Paget's, osteogenesis imperfecta. For hypocalcemia, you want to correct for the albumin, recheck it, see if there's low magnesium, if they had a transfusion, it could be citrate, were there any drugs, is it CKD, malnutrition, some sort of acids. And then you want to check, parathyroid, see if it's low, normal, or high. If parathyroid is high, then you could have metabolic disease, CKD, sepsis, or parathyroid resistance. And if PTH is normal or low, it could be because of surgery, autoimmune disease, infiltrative cancer, or something genetic. Hypercalcemia, you also want to get a PTH to see if it's PTH dependent or independent. Treatment is fluids and diuretics if you have acute hypercalcemia. And you can also use cinacalcet, which blocks the calcium sensing receptors. Let's talk about congenital disorders. So if you have androgen sensitivity, then you'll have minimal pubic hair. You'll be 46 XY, but you'll look female. If you have Müllerian agenesis, then you can do a renal ultrasound and you see there's no uterus. You have a blind vaginal pouch. You do have your ovaries, so you have secondary sex characteristics, but you don't have the upper vagina and you don't have a uterus, so you'll have primary amenorrhea. With Turner disease, you'll see that on echo. You'll have delayed puberty. With 5-alpha reductase deficiency, genotypically you'll be 46XY, just like in androgen sensitivity syndrome, and you will look female until puberty when you start to look male. Let's see, for Cushing's disease, so you can have either endogenous or exogenous cortisol. You can have ectopic ACTH, paraneoplastic syndrome from squamous cell lung cancer. You can have primary ACTH, pituitary adenoma. You can have Cushing's disease of the adrenal glands. So the way you test for this is a 24-hour urine cortisol or late night cortisol level or dexamethasone suppression. You'll also have increased cortisol, so you'll have hyperglycemia. Excess aldosterone leads to hypernatremia and low potassium and a high blood pressure. You'll have muscle weakness, bruising, coagulopathies. You can have increased weight, headaches, bone pains, osteoporosis. You can have Nelson syndrome, which is hyperpigmentation. Differential for chronic diarrhea. You want to figure out if it's nocturnal. So chronic diarrhea greater than 4 weeks. If it's nocturnal, then it's usually secretory. It happens during sleep, whether or not you're fasting. The workup for that includes infection, cancer, microscopic colitis. That would be a mononuclear inflammatory infiltrate, and the treatment for that is to reduce the inflammation with steroids like budesonide and avoiding the triggers. If you have a nocturnal diarrhea, that needs a workup because that can be something like cancer or an infection. IBS could also be causing chronic diarrhea. That's a change in frequency, form, and with IBS, you'll have pain that's relieved with defecation. You can also have diarrhea with carcinoid syndrome. That'll also have right heart murmur, telangiectasias, low niacin. You can also have thyrotoxicosis. The treatment for that is beta blockers and MTU or MT, methimazole and PTU. You can have pellagra, which is niacin deficiency B3. They'll also have vesicular rash and dementia. That's a high corn diet. You can also have bile salt insufficiency with Crohn's, pancreatic insufficiency, giardia, which will be foul smelling, travel history. And microscopic colitis, which I talked about already, but that has collagen bands on pathology. And so that is a secretory due to the mononuclear inflammatory infiltrate. If you have low salt, high potassium, you want to think about low aldosteronism. And if you have low blood pressure and fatigue, you want to think about low cortisol. So if you have mineralocorticoid insufficiency and glucocorticoid insufficiency, you want to think of adrenal insufficiency. This will also have low libido, low sex drive. You might have on labs peripheral eosinophilia, and that's also pathognomonic for primary adrenal insufficiency. You'll see high ACTH as well as off-target hyperpigmentation. Secondary insufficiency will have low ACTH. Primary causes for that would be worldwide things like TB and viruses versus primarily Addison's in the developed countries. So you have milk alkali syndrome, which can cause hypercalcemia and metabolic alkalosis. This will cause constipation, abdominal pain, increased urination and thirst. It might even look like diabetes because of all the polyuria. But that is due to decreased renal blood flow and a decrease in sodium potassium to chloride pumps because there's more calcium ions in the tubule lumen. So you have a loss of sodium in the urine, leading to hypovolemia and the contraction alkalosis. This can also be caused by over-the-counter vitamin supplements being taken for osteoporosis. If you have a rash that's painful, it's crusty, and has a central clearing, and you also have diarrhea and anemia and type 2 diabetes, you want to think of a pancreatic islet cell tumor, specifically a glucagonoma. You diagnose that with labs and CT abdomen. Going back to the adrenal insufficiency, you can test for that with a cosentropin test to diagnose primary insufficiency. If you have hypopituitarism signs, then that's usually secondary, and tertiary is usually occurring with steroids. If you have hypogonadism, you might have either primary or secondary. Primary means there's something wrong with the actual testes. Secondary means there's something wrong with the HP axis, hypothalamic pituitary axis. Interestingly, cirrhosis can cause both. Cirrhosis can cause both primary and secondary. But the way you differentiate it is you get a testosterone level. If it's truly low, with low testosterone, you also want to get an LH level. If you have low testosterone but high LH, FSH, then you know it's something wrong with the primary. That could be testicular atrophy, steroid use, dysgenesis, myotonic dystrophy. Shout out to Gilbert Gottfried. If you have low or inappropriately normal LH, that could be due to gonadotropic suppression like steroids or gonadotropic damage. That could be secondary to opioids, tumors like a prolactinoma, infiltrative diseases like hemochromatosis in the pituitary or sarcoid. And you want to check prolactin levels, see if they're on steroids, do an MRI of the pituitary. If it is truly a prolactinoma, you can use dopamine agonists like cabergoline, which inhibit prolactin. And prolactin, in turn, inhibits GnRH, which is the pathophys behind decreased sex steroid gonadotropic transmitters. You can also see zinc deficiency causing hypogonadism. And if you have secondary hypogonadism, you want to do the workup for the pituitary adenoma, see if it's functioning. And you can also, remember, check primary testicular deficiency. Something could be congenital or CKD. Also, CKD can sometimes cause primary testicular deficiency. Let's talk about precocious puberty. So if you're suspecting precocious puberty, what you want to get is bone age. Bone age will tell you what side of the algorithm you're looking at. If you have normal bone age, then it's probably just premature thylarchy and adrenarchy. If you have increased bone age, then you want to check your basal LH and GnRH stimulation of LH. If your luteinizing hormone is low after stimulation, then you know it's a peripheral issue. And you want to check for CAH21 hydroxylase, McCune-Albright. You'll see acromegaly with increased IGF-1 that can be related to colorectal cancer, heart failure, and vascular disease. If you did a GnRH stimulation of LH and LH went high, then you know that's a central issue, and it could be idiopathic, so you want to treat that with a GnRH agonist, or it could be a CNS lesion, so you get an MRI. So puberty, get bone age. If bone age is high, get a GnRH stimulation test. If it's a high LH dependent on GnRH stimulation, then it's central, and you want to get an MRI, look for any CNS lesion. If you have someone with hypertension and you suspect it could be salt retaining, potassium wasting, you want to suspect hyperaldosteronism. So you get a renin-aldo level and CT of the adrenals. Aldosterone-renin ratio will usually be high. You can also do a post-saline infusion or adrenal venous sampling. Once you do the CT, if it looks normal, you can do the adrenal venous sampling. If the CT shows an adenoma, then you usually want to do surgery. If it's unilateral and if it's bilateral, you can do medical treatment. If it's non-aldo, non-renin hypertension, then you want to consider other enzyme deficiencies, like in 17-hydroxylase. You'll have those levels elevated because of congenital adrenal hyperplasia from 21-hydroxylase deficiency. You could also do a cortisol DEXA suppression test to look for Cushing syndrome from exogenous versus endogenous, could be ectopic, get an ACTH level. Metanephrines and a CT abdomen pelvis will look for a pheochromocytoma. Think of MEN2A2B or VHL or even neurofibromatosis. You get calcium and PTH levels. That will be high in primary hyperparathyroidism, which will lead also to hypertension. And if you have unilateral hypertension in one arm versus the other, you can think of coarctation or even dissection. So going back to the cortisol, Cushing's algorithm. So first you want to get a cortisol level. And if you see that is low, then you want to get an ACTH level. If the ACTH level is low or normal, then you know that's either exogenous input of cortisol, and that's leading to suppression, or there's something primary with the adrenals going on, like an adrenal adenoma, carcinoma, or hyperplasia. So either way, you want to get a CT scan for that. If you do a cortisol, the cortisol is low, and you get the ACTH, and the ACTH is high, then you know that your pituitary is trying to do some funny business with you. So you want to check the pituitary with a scan for pituitary adenoma, and if it's not that, then it could be ectopic. It could be ectopic ACTH, just like there's ectopic PTH. So it's analogous there. So you want to do scans for small cell lung cancer. Just remember one more time, with secondary hypogonadotropic hypogonadism, there could be GnRH suppression from an excess of prolactin. But if your TSH and prolactin are fine, then you want to look for other causes, like something like, were there any medication uses, like opioids? Opioids can also suppress GnRH, leading to low LH, leading to low testosterone, low sex drive. The other things that can suppress GnRH endogenously are TRH and prolactin. If you get a CMP with sodium, potassium, and chloride, you always want to calculate an anion gap. If you have DKA versus HHS, then usually you want to give both of them fluids, and later on you can give insulin to HHS, but DKA needs insulin immediately. You'll also want to replace potassium if it goes below 5.3. You can give bicarb if pH is 6.9. You can give phosphate if that goes less than 1. And in general, for DKA, you want to overlap the basal infusion of insulin with subcutaneous. So if you have IV insulin, overlap with the basal subcutaneous insulin, and then you also want to do that when there's an anion gap that's been closed and the bicarb is at least 15. And you want to give some dextrose in water if the glucose starts to go below 200. So you want to avoid hypoglycemia. So if you're ever wondering why there's hypogonadism and hemochromatosis, the answer is that there's iron deposits in your brain. And so that leads to secondary hypogonadotropic hypogonadism. So you'll have suppression of GnRH, low LH, and low testosterone. You'll also have hepatomegaly, diabetes. You want to get a ferritin level to rule out other causes of the increased iron, and the treatment is phlebotomy. If you have selenium, that can affect your thyroid, heart, and red blood cells. Let's say you're wondering if someone has a growth delay or if they actually have growth hormone deficiency. If you cross 2 or more major percentiles, then you want to get a reflex IGF-1 to look for growth hormone deficiency versus something like constitutional growth delay. For infertility, you want to look at the FSH and LH. Primary infertility, you'll have high GnRH, FSH, LH, but for some reason your gonads are not working, so you want to look at things like Klinefelters in someone who's phenotypically male. They'll actually be genotypic 47XXY, and that's secondary to tubule dysgenesis. And if someone looks phenotypically female, you want to consider Turner syndrome for primary infertility. The differential for eosinophilia is acute interstitial nephritis, adrenal insufficiency, neoplasms, ALL, but also other things like collagen vascular disease, parasites, asthma, and other medications. One big concern with downstream effects of hyperthyroidism is an increase in osteoclast activity, which breaks down bone and leads to osteoporosis. So thyrotoxicosis, which can appear apathetic in elderly population, thyrotoxicosis like Graves', toxic multinodular goiter, or a single toxic nodule adenoma. Those last two are TSH independent versus Graves', which is has the antibodies that hit the TSH receptor. But regardless, thyrotoxicosis, you want to treat symptoms with beta blockers and treat the disease with PTU and methimazole. Either way, you want to do either surgery or radioactive iodine. You would not want to do radioactive iodine if they just had contrast-induced thyrotoxicosis, like in the setting of a heart catheter procedure. If you have a thyroid nodule, the workup is to get a TSH and ultrasound. If the TSH is high or normal, then you want to do an FNA. If you have low TSH, then you want to do radioactive iodine uptake, which looks for the hyperthyroid homogeneous or nodular Graves versus toxic multinodular adenoma or goiter. If you have high radioactive uptake, then treat the hyperthyroidism. If you have low radioactive uptake and low TSH, then it's a cold nodule, and that needs an FNA for possible cancer. And if it is a suspicious nodule on ultrasound, you also want to do an FNA. If the suspicious nodule turns out to be cancer, thyroid cancer needs a lobectomy if it's less than, well, first you want to stage it and see if there's any extrathyroid extension, metastasis, any history of head and neck radiation. That will also need a thyroidectomy, or if it's large, PTC. But in general, if it's less than 1 millimeter, you do a lobectomy. If it's greater than 1 millimeter, or there are those risk factors, then you do a thyroidectomy. And if it's medullary, do you want to get a calcitonin level and look for a pheochromocytoma with metanephrines because of MEN2A and 2B association. You do not want to do a surgery on a medullary thyroid if you haven't found the pheo because of intraoperative complications with hypertension. It is possible to have subclinical hyperthyroidism where you have a suppressed TSH but normal hormone levels, and you might not have any clinical symptoms. Usually you want to recheck the TSH later, but you might need to treat this, especially if they're older, they have heart disease, osteoporosis, nodular, or if it's they're persistently low, suppressed TSH, then you want to treat the subclinical hyperthyroidism. Hyperthyroidism treatment, the mainstays are beta blockers for symptoms, methimazole, PTU, and prednisone. That helps with decreased peripheral conversion, which also is good in thyroiditis, and radioactive iodine uptake, but not if they just had a contrast study like a catheterization. And if after you've started anti-thyroid hormone drugs, you want to recheck the T4 and T3 levels within a few weeks. And then months later, you want to check a TSH, but not right away because the TSH may remain suppressed for months. And you also want to pre-treat with anti-thyroid drugs anytime prior to surgery or radioactive iodine. Now, let's say you've discovered hypothyroidism. First, you want to check to make sure it's not central. So if you have low TSH and low T4, you want to check central. This might be causing adrenal insufficiency as well. Get an AM cortisol, that might be low or normal. Glucose levels will also be low. An ACTH and stim test will show appropriate response, and that will be a primary adrenal insufficiency. However, if there's normal cortisol response, then you want to check an ACTH because that might be low and it's actually secondary central adrenal insufficiency. So you might need to get an MRI to check the pituitary. If you have a non-suppressible TSH secretion, so you have really high TSH, you want to think hypothyroidism secondary to a pituitary adenoma. And if you have a pituitary adenoma causing TSH secretion, then treatment might be resection if there are compressive effects or if there's any hormone dysfunction, thyrotoxicosis, mass effects. If you have thyroid hormone resistance syndrome, you have a beta gene mutation and high TSH, that'll be a diffuse goiter, but normal sex-binding globulins, normal pituitary hormones, and a normal alpha subunit level. That's opposed to a pituitary adenoma that's secreting TSH, that'll have high alpha subunits and high sex hormone binding globulin. You could also have exogenous thyroxine suppression of TSH. So that will actually be a low TSH, low thyroid binding globulin, and high T3, T4. So you'll be clinically hyperthyroid. Hyperestrogen states like pregnancy also increases the TBG. So your T3, T4 is high, but your TSH is low or normal. The HCG subunit acts alpha subunit acts on TSH receptors, making more T4, but that actually causes negative feedback on the pituitary, so the TSH might be low normal, and they're usually clinically euthyroid, except if at baseline the pregnant woman had hypothyroidism and they can't mount the same response, so the T4, T3 might actually be low, and so you need to increase levo by 30%. If they're on lithium, just keep giving the levothyroxine because even if there's a lithium-induced hypothyroidism, that usually goes away on its own. And remember, with lithium, thiazides, aspirin, and ACEs, those all increase lithium levels. Thiazides, aspirins, and ACEs. Let's talk about hyperthyroidism again. So if there's a diffusely enlarged, non-tender thyroid, you want to think of Graves. That will have increased uptake that's homogeneous on radioactive iodine. If you have a non-tender small goiter, you might think of painless silent thyroiditis. That's autoimmune, TPO antibodies positive, associated with women, and postpartum. You might also have OB-GYN complications, miscarriages. Hashimoto's is associated with recurrent miscarriages, placental abruption, preterm birth, low birth weight. Diagnostics for this is the anti-thyroid peroxidase hormones. Treatment is NSAIDs and beta blockers. If you have a painful diffusely large goiter, which is the opposite of Graves and silent thyroiditis, this is subacute thyroiditis or Dequervain's. You're going to have hyperthyroidism, low TSH, and low uptake, usually post-viral. And if you have low T3 but normal T4 and TSH in a sick person, that's usually euthyroid sick syndrome. The TSH and T4 are usually normal. Sometimes the TSH might eventually decrease, but it's because they're in a sick state and they have decreased peripheral conversion of T4 to T3 due to a non-thyroidal illness. Medications for your thyroid, remember that beta blockers stop peripheral conversion of T4 to T3. Prednisone is good for lid lag and ophthalmopathy, but you might need to do surgery or radioactive iodine for that. Methimazole for hypothyroidism can cause neutropenia and is teratogenic, so if there is pregnancy, you want to use PTU, which is safe for pregnancy, although that may cause hepatotoxicity. All right, remember that the thyroid diverticulum arises from the floor of the primitive pharynx and descends into the neck. It's connected to the tongue by the thyroglossal duct, which normally appears to to leave during development, but it may persist as a cyst or the pyramidal lobe of the thyroid. Remember, the foramen cecum is the normal remnant of the thyroglossal duct, and the most common ectopic thyroid tissue is at the site of the tongue, or the lingual thyroid. Removal may result in hypothyroidism if it is the only thyroid tissue left. And the thyroglossal duct cyst presents as an anterior midline neck mass that moves with swallowing or protrusion of the tongue, versus a persistent cervical sinus, which leads to a branchial cleft cyst in the lateral neck, as opposed to the anterior. Thyroid follicular cells are derived from the endoderm, so parafollicular cells, aka C cells, produce calcitonin. C cells, calcitonins, both start with C, and those are derived from the neural crest. Your adrenal cortex, with your adrenals, so you have the adrenal gland, adrenal cortex under the capsule, cortex, and then medulla. And within the cortex, you have the zona G, zona F, zona R, and in the medulla, you have chromaffin cells. So you have primary regulation of the zona G by angiotensin II, and the rest of the cortex is under control of ACTH and CRH. The hormones produced here in the GFR zones are mineralocorticoids, glucocorticoids, and androgens. And the hormones produced are aldosterone, cortisol, and DHEA. So that'll be important for tumors. And in the medulla, the chromaffin cells are neuroendocrine. They produce catecholamines. They're regulated by the preganglionic sympathetic fibers, and they produce the catecholamines. So they produce epinephrine, norepinephrine. The pituitary gland, so you have the anterior and posterior pituitary. Anterior pituitary does FSH, LH, ACTH, TSH, prolactin, growth hormone, don't forget growth hormone, and IGF-1, beta endorphins. Melanotropin, that's seen in secondary, or not, that's seen in primary adrenal insufficiency. And the anterior pituitary comes from the Rathke's pouch, or the oral ectoderm, and that also creates the alpha subunit, which is both common in TSH, LH, FSH, and beta HCG, or HCG rather, and that's imported in the hyperemesis gravidarum and hydatidiform moles. Remember that ACTH, melanotropin, and beta endorphins are derivatives of propiomelanocortin, so that'll have the hyperpigmentation. And B flat is for basophils, FSH, LH, ACTH, TSH, and acidophils are GH and PRL. The posterior pit does vasopressin and oxytocin. Vasopressin, another name for that is ADH. The oxytocin and vasopressin are both produced in the hypothalamus, and that's transported down the posterior pituitary via the neurophysins, and that's derived from the neuroectoderm. Your pancreas cell types, your islet cells, are your alpha, beta, and delta, which correspond to glucagon, insulin, and somatostatin, and those are from outside to in. So your alpha is peripheral, beta is central, somatostatin is interspersed. So insulin goes through the cleavage stage and produces the C-peptide. So if you have exogenous insulin, then there'll be a low C-peptide. Insulinomas and sulfonylurea use, however, will upregulate C-peptide. Basically, there are different glucose transporters that are dependent or independent of insulin. The only dependent insulin one is GLUT4. So that's in striated muscle adipose tissue, which is important. And all the independent insulin transporters are pretty much everywhere else. The brain uses glucose for metabolism, but it transitions to ketone bodies during starvation. Glucose, I don't need to go through that. Glucagon made by the alpha cells. Remember, glucagonoma will have the central clearing rash, diarrhea, dementia, hypoglycemia, hyperglycemia. The HPA, pituitary hormones, so ADH or vasopressin, that retains water in the collecting tubules. Too much of that will cause SIADH, which is euvolemic hyponatremia. You can treat that with inhibiting ADH, like with Vaptins. Cortisol releasing hormone from the hypothalamus, just like ADH comes from the hypothalamus, that is suppressed in chronic exogenous steroid use. So you can have tertiary adrenal insufficiency with that. Dopamine functions to inhibit prolactin and TSH. Dopamine antagonists will lead to excess prolactin and then galactorrhea. GHRH, growth hormone releasing hormone, that will increase growth hormone. The analog tesamorelin is used to treat HIV-associated lipodystrophy. She should have gotten that. GnRH increases FSH and LH. Your LH goes to your luteal cells, and then your theca cells, FSH. That's suppressed by hyperprolactinemia. And if you have pulsatile GnH, that is the active form, and that leads to puberty and fertility. But if you have constant suppression of GnRH, that will suppress the axis. If you have infiltrative diseases like sarcoid or hemochromatosis, that will also lead to suppression of GnRH. MSH causes hyperpigmentation. Oxytocin, that's milk letdown and uterine contractions. So oxytocin is first-line treatment after just physical pressure on the uterus. If there's uterine hemorrhage, you can also give oxytocin to contract down. Prolactin causes galactorrhea, and it also inhibits GnRH. So if you have too much prolactin from an adenoma, you can actually have amenorrhea, osteoporosis, hypogonadism. Somatostatin, analogs of that is octreotide. That's used to treat acromegaly. It suppresses growth hormone and TSH. And TRH leads to the stimulation of TSH. So increased TRH will be seen in hypothyroidism, and it also off-target stimulates prolactin. So you might even have prolactin secretion leading to galactorrhea if there's hypothyroidism. So again, prolactin comes from the anterior pituitary. Too much of prolactin is associated with decreased libido because of the suppression of GnRH. Treatment of a prolactinoma is something like cabergoline. We don't use bromocriptine anymore, really. You might also need to do surgery, but that's only if it doesn't work with medical management. And remember, too much prolactin will inhibit GnRH, which stops ovulation, which stops spermatogenesis. You have growth hormone, which is somatotropin that's secreted by the pituitary. That stimulates muscle mass and linear growth through IGF. If you have too much growth hormone, that could be causing acromegaly or gigantism. You want to treat that with somatostatin analogs like octreotide or surgery. Remember, acromegaly can cause cardiovascular issues. Appetite regulation, you release ghrelin when you're hungry. You have too much ghrelin in Prader-Willi syndrome. Leptin makes you thin. That suppresses your hypothalamic satiety center. And cannabinoids act on the hypothalamus to increase and stimulate appetite. Vasopressin ADH from the posterior pit will act to retain free water, which will decrease your serum osmolality, increase your urine concentration because of aquaporins. This might be either due to diabetes insipidus or nephrogenic DI. If you have nephrogenic DI, then you might have insensitivity to ADH at the V2 receptor. And if you have nephrogenic, if you have central DI, then you just don't have ADH. An ADH analog can be used to treat central DI, and you can also use it for nocturnal enuresis. Adrenal steroids and congenital adrenal hyperplasias. The most common is 21-hydroxylase. That will shunt everything to your androgens, so you'll be virilized and have hirsutism. If you have 11-beta hydroxylase, then that will shunt things also to your androgens, but you'll have an increase in 11-deoxycorticosterone as well. And if you have 17-alpha hydroxylase deficiency, then nothing goes to your glucocorticoids and nothing goes to your androgens. So it's just your zona glomerulosa that's being stimulated. Remember, angiotensin 2 actually is the only one that controls your aldosterone in the zona glomerulosa, so you can still have some of that being converted. ACTH stimulates the others through cholesterol desmolase, and ketoconazole actually stops steroidogenesis. So again, 21-alpha hydroxylase, 21-hydroxylase is the most common congenital adrenal hyperplasia. It presents in infancy with salt wasting or in childhood with precocious puberty, and females will be virilized. Then you'll have lab findings that show increased 17-hydroxyprogesterone. If you have 11-beta hydroxylase deficiency, you'll also have females that are virilized, but you'll have decreased renin activity because you have enough of the 11-deoxycorticosterone, which leads to an increase in blood pressure. So actually your renin will be low as it tries to suppress that. And then 17-alpha hydroxylase will shunt everything away from your androgens. So you will have ambiguous genitalia in XY with undescended testes, and then XX will lack secondary sexual development. And you'll have a drop in labs of androstenedione. Your mineralocorticoids will be fine. They'll be elevated. You'll also have high blood pressure and low potassium. But your cortisol and sex hormones will be low. And all of these deficiencies are characterized by skin hyperpigmentation due to the increased ACTH stimulation and off-target increase in MSH production, which is co-produced and secreted with ACTH. You'll also have bilateral adrenal gland enlargement. And just a fun way to remember things, if the enzyme deficiency starts with a 1, it will cause hypertension. And if the deficiency enzyme ends with a 1, it will cause virilization in females. So that'd be 11, 17, and then 21. So cortisol made in the fasciculata controls your blood pressure, your appetite, insulin resistance, fibroblast activity, so you'll have too much of it will cause poor wound healing, inflammatory response, and bone formation. So lots of things with your immune response and cortisol. It can actually block IL-2, block production of leukotrienes, prostaglandins, stop white blood cell adhesion, histamine release. Calcium homeostasis. So plasma calcium can either be free, which is active, or bound to albumin. If you have an increase in pH, then you have less hydrogen ions, and so you'll actually have you'll have less hydrogen ions competing with calcium for albumin, so you'll have hypocalcemia with spasms, paresthesias. And remember, free calcium is the primary regulator of PTH. Changes in pH alter PTH secretion. However, changes in albumin do not change PTH secretion because it's only the free calcium that changes PTH. So where does PTH come from? It comes from the chief cells in your parathyroid. They function on your bone to increase resorption of calcium and phosphate, on the kidneys to reabsorb calcium and excrete phosphate, and it directly controls the hydroxylation of 25 to 125 calcitriol production in the kidney. There can also be PTHRP formed by squamous cell cancer of the lung or renal cell carcinoma causing malignant hypercalcemia. And the way this works is you have bone resorption because the rank ligand receptor is activated. It binds to the rank receptor on osteoclasts and their precursors to stimulate osteoclasts and calcium resorption. Also, if you have low magnesium, that stimulates PTH secretion. And if you have too low magnesium, it'll actually stop PTH secretion. So when you think about low magnesium, you want to think of diarrhea. You want to think of diuretics. You want to think about alcohol abuse. Calcitonin also comes from that same region of anatomy, but they do not come from the chief cells. No, they come from the parafollicular cells of the thyroid. And calcitonin acts diametrically opposed to PTH. Calcitonin says, I don't want as much calcium. I want to keep it in my bones. So they actually lower the calcium in your blood. Now let's talk about the thyroid hormones. So T3, T4. T3 is the free active hormone. We get there from the follicles of the thyroid, which converts the T4 to T3 in the periphery. Peripheral conversion is inhibited by beta blockers, glucocorticoids, PTU, methimazole. In the thyroids, in the follicles, you have thyroid peroxidase, which creates the function oxidation or an organification of the iodide and the coupling of MIT with DIT to form T3, or DIT and DIT to form T4. And if you have too much iodine, that will actually temporarily stop the thyroid peroxidase, and that's the Wolff-Chaikoff effect. T4 is important for brain, bone, beta adrenergic effects like on the heart, basal metabolic rate, oxygen consumption, temperature of the body, breathing. Blood sugar increases gluconeogenesis, glycogenolysis increases blood sugar, and breaks down lipids, so it increases lipolysis. It's regulated by TRH and TSH, acting on the follicular cells, and you might also have antibodies against thyroid peroxidase, which will decrease its activity. And remember, thyroid binding globulin is how your hormones get around the blood until they get decoupled and become active. You can have increased TBG with high estrogen states, things that are catabolic, that build like pregnancy or contraceptive use. You'll have decreased TBG in cirrhosis, steroids, or nephrotic syndrome. Cushing's disease, we have 3 ways to test for it. Cortisol in the morning, low dose suppression, or free cortisol over 24 hours. You want to measure serum ACTH along with that. To diagnose Cushing's, you want to see that there's excess cortisol. So you can grab 24-hour urine cortisol, or a nadir cortisol, or dexamethasone suppression. Once you see that there's high cortisol, you want to get an ACTH level to see if this is ACTH dependent, like Cushing disease or something ectopic secreting ACTH, or if it's ACTH independent, and if it's suppressed, then you know it's something exogenous. So if cortisol high, then measure ACTH. If ACTH high, then it's endogenous. If ACTH is low, then it's exogenous. Or it's an adrenal tumor, and you want to get an adrenal CT. If your ACTH is elevated, then you want to look for something that is ACTH dependent Cushing's. So you want to do a high dose dexamethasone suppression test. If there's no suppression of your ACTH, then you know ACTH is ectopic somewhere. You want to get a CT chest, abdomen, pelvis. If you do have adequate suppression of that, then you know it's Cushing's disease, and you want to get an MRI of the pituitary. If you did a CRH stimulation test and your ACTH and cortisol were high, that's also diagnostic of Cushing's disease. You want to get an MRI of the pituitary. And if you do a CRH stim test and there's no increase in ACTH or cortisol, then you know it's also ectopic ACTH, and you want to do a CT abdomen, chest, pelvis. So the sources of cortisol can be either outside or inside. If it's outside, then you'll have a suppressed ACTH, bilateral adrenal atrophy, and that's usually the most common cause of Cushing's syndrome. We're just causing it. We're giving too much steroids. It could be endogenous from an adenoma of the adrenals, hyperplastic adrenal glands, or carcinoma. These will also be causing suppressed ACTH because of feedback on the central nervous system. And this will have atrophy, but of the uninvolved adrenal gland. And if it is an ACTH secreting pituitary adenoma, then that is Cushing's disease. So that is something that has elevated ACTH, or it might be ACTH being secreted from a perineoplastic cancer. So bronchial carcinoid tumor, small cell lung cancer, renal cell. If you have increased ACTH, then you'll have bilateral adrenal hyperplasia, and for the most part, Cushing's disease is the most responsible for the majority of endogenous cases. If you have someone who's coming in with adrenal insufficiency, they'll present with weakness, fatigue, hypotension, muscle pain, weight loss, hypotension, especially orthostatics, sugar and salt cravings. Treatment for this is glucocorticoids and mineralocorticoids. The workup, you could use, you can get a random morning cortisol and ACTH. If it's low cortisol and high ACTH, then you know it's probably a primary adrenal problem. And if there's low ACTH, then you know it's something central, like secondary with the pituitary or the hypothalamic. And that'll also have a low response to ACTH stim test. Alternatively, you can use metyrapone stimulation test. That blocks the last step of converting deoxycortisol into active cortisol. So a normal response is to decrease your cortisol, and there'll be a compensatory increase in ACTH and 11-deoxycortisol. In primary adrenal insufficiency, ACTH is increased, but the 11-deoxycortisol remains low after the test, so you're not able to actually convert it to cortisol. And in secondary and tertiary adrenal insufficiency, both ACTH and 11-deoxycortisol remain decreased after the test. Remember Waterhouse-Friderichsen syndrome, acute primary adrenal insufficiency after adrenal hemorrhage with something like septicemia from Neisseria or DIC or endotoxic shock. Chronic adrenal insufficiency due to adrenal atrophy or destruction by disease like autoimmune diseases like TB. You'll also have metabolic acidosis from all the loss of cortisol and aldosterone. You'll have hyperkalemia and volume contraction. On the flip side of things, if you have something like low pituitary ACTH, then you'll have secondary adrenal insufficiency. You won't have the hyperkalemia because aldosterone synthesis is preserved due to the intact RAS system, so you're not going to have this big spike in aldosterone. Angiotensin 2 will be working on the zone G to keep that going at a normal amount. And it will spare the skin and mucosa, so you won't have the off-target MSH forming, hyperpigmentation. And then tertiary adrenal insufficiency, that's when we give someone chronic exogenous steroids. So chronic exogenous steroids can cause Cushing's, that's has low suppressed ACTH, or it can also cause tertiary adrenal insufficiency. Now let's go on to hyperaldosteronism. If you have primary hyperaldo, that's usually an adrenal adenoma or Conn syndrome, or you can have bilateral adrenal hyperplasia, high aldo, low renin, causing resistant hypertension. Secondary hyperaldo, that's seen in folks with renovascular hypertension or renin-producing tumors or edema from heart, liver, or kidney failure. And so this will have definitely secondary causes of hyperaldo, like the heart failure, will impair aldosterone escape mechanisms, leading to worsening edema. However, in primary hyperaldosteronism, that does not directly cause edema due to aldosterone escape. There will be hypertension, low or normal potassium, and metabolic alkalosis from all the aldosterone and contraction alkalosis. But you will not have edema in primary hyperaldo. You will have edema in secondary hyperaldo, but that's because there's also edema from whatever was causing it. Next, we have neuroendocrine tumors. These are arising from neuroendocrine cells that have traits similar to nerve cells and hormone-producing cells. So like the neuroendocrine cells in the medulla, or the insulin-producing beta cells in the pancreas. So you can have tumors in the GI system, like carcinoid and gastrinomas, pancreas with insulinoma and glucagonoma, and the lungs with small cell carcinoma, the thyroid medullary carcinoma, or the adrenal pheochromocytoma. The neuroblastoma is the most common adrenal medulla tumor in children. It originates from the neural crest, and it is an irregular mass that can cross the midline, whereas Wilms is smooth and unilateral. Wilms is less likely, neuroblastoma is less likely to develop hypertension than with a pheochromocytoma. So neuroblastoma is normotensive. It can present with the opsoclonus, myoclonus, dancing eyes, dancing feet syndrome. It will have increased HVA and VMA catecholamine metabolites, as well as on pathology it shows Homer-Wright rosettes, characteristic of both the neuroblastoma and medulloblastoma. It will be bombacin and NSE positive stain associated with overexpression of NMYC oncogene. Pheochromocytomas associated classically with MEN2A, MEN2B, but also in neurofibromatosis 1 and VHL. So don't forget those two. It's the most common tumor of the adrenal medulla in adults. So the neuroblastoma is to kids, what the pheochromocytoma is to adults. Again, grab the catecholamines and metanephrines in the urine, treat it with alpha antagonists, specifically phenoxybenzamine, to prevent the beta, the unopposed alpha activity. You can have a rare neuroendocrine tumor of the vasoactive intestinal peptide, or VIP. and that also commonly arises in the pancreas. So that will have watery diarrhea, hypokalemia, and lack of acid. Hyperthyroidism. Basically, hyperthyroidism will have a very low TSH if it's primary, and high free T3 and T4, low LDL and total cholesterol. Hypothyroidism will have an elevated TSH if it's primary. Remember, with either hyper or hypothyroidism, you always want to consider if it's something secondary. So is it above the thyroid, coming from the hypothalamus with TRH, or with the pituitary with TSH? Different types of hypothyroidism includes Hashimoto's, postpartum thyroiditis, congenital hypothyroidism, subacute granulomatous thyroiditis. That'll be after a viral infection. It'll be a very tender, inflammatory thyroid. And Rydell thyroiditis is associated with IgG4 fibrosing diseases. So it might also have autoimmune pancreatitis, non-infectious aortitis, and retroperitoneal fibrosis. That is a rock-hard, painless goiter. And then other things could be iodine deficiency. That can also be caused by lack of ingestion. You can also have amiodarone or hypothyroidism from response to iodine, the Wolff-Chaikoff effect. Hyperthyroidism, so you have diffuse homogeneous hyperthyroidism, a diffusely enlarged goiter, which is Graves' disease. On histology, that will be tall, crowded follicular epithelial cells representing a scalloped colloid. You can have many sort of focal patches of hyperthyroidism, which is toxic multinodular goiter. You can have a single adenoma. You can have also a thyroid cancer or thyroid cyst. Hyperthyroidism can cause thyroid storm, and this will be sort of in the setting of an acute stressor like an infection or trauma or surgery. You'll have tachyarrhythmias, which is the most common cause of death, but also fevers, delirium, agitation. So this thyroid storm needs to be treated with the 4 Ps, so propranolol, which is beta blocker, PTU, prednisolone or steroids, and potassium iodine. And if you have someone who has iodine deficiency, and you make them iodine replete, then that can also induce thyrotoxicosis. So it can happen after iodine IV contrast. Again, a thyroid adenoma, it's a single growth of the thyroid. It's usually benign. Most are cold, non-functional. It can rarely cause hyperthyroidism. The most common histology is follicular, has the absence of a capsular or vascular invasion that is normally seen in follicular carcinoma. Thyroid cancer has different divisions. Remember, it could be lymphoma, thyroid lymphoma associated with Hashimoto's. It could be one of the worst kinds is undifferentiated or anaplastic carcinoma. And then the familiar ones are medullary, which is parafollicular C cells, calcitonin associated with MEN2A, MEN2B, RET mutations, sheets of amyloid in the stroma. It stains very well with Congo red. There's follicular, which invades the thyroid capsule and vasculature. Hematogenous spread is usually uncommon. It's associated with RAS mutations and PAX8, PPAR gamma translocations. Remember, PPAR gamma, that's the way that thiazolidinediones work. It has a better prognosis. Papillary carcinoma also has a good prognosis. It has empty appearing nuclei with central clearing. These are the orphan Anni-eyes, Samoma bodies with the calcifications, and nuclear grooves. So that is also associated with BRAF mutations, childhood radiation, and has a good prognosis. Mass effects of any of these cancers could be, dysphagia, could be, you can have dysphonia, and hypocalcemia once you remove the thyroid, so that could be because of removal of parathyroid glands, or even hoarseness. The way you diagnose parathyroid disease is you want to get a PTH level. If it's PTH dependent, then PTH is going to be high, and it will be causing hypercalcemia. Primary hyperparathyroidism will be a hyperplasia, adenoma, or carcinoma. If it's PTH independent, then you have high calcium, but it's not because of PTH. So then you want to look at, maybe is it cancer, maybe it's PTH related peptide, maybe it's excess calcium intake, maybe it's too much vitamin D. And then you might have hypocalcemia, and so that can be hyperparathyroidism, which is secondary, so something like CKD, vitamin D deficiency. And then if you have low calcium and low PTH, then that's primary hypoparathyroidism, again, sort of like a resection from thyroid cancer or something autoimmune. So other things that cause hypoparathyroidism, the resection or autoimmune destruction. So autoimmune things could be a pseudo-hypoparathyroidism, where your kidneys are not responding to PTH. Remember, PTH acts on the 1-alpha hydroxylase in the kidneys to form the active vitamin D, but you'll have hypocalcemia despite increased levels of PTH. This can also present with Albright hereditary osteodystrophy, shortened digits on the fourth and fifth fingers, developmental delay, short stature. It is autosomal dominant, and its defect is inherited from the mother due to imprinting. So it's kind of similar to the imprinting diseases of Prader-Willi. And then there's pseudo hypoparathyroidism, which has all the features on physical exam of Albright hereditary osteodystrophy, but without the end organ PTH resistance. So your PTH levels will be normal. And this actually is a defective subunit inherited from the father. And if you see, if you tap the facial nerve, you have Schwastik's sign, you tap the cheek, and it has contractions of the facial muscles, or occlusion of the brachial artery with the blood pressure cuff that can cause a carpal spasm. These are tetany symptoms and signs of hypocalcemia, and can also be seen in DeGeorge syndrome. Hyperparathyroidism, there's primary, secondary, and tertiary. Tertiary, it's autonomous hyperparathyroidism resulting from long-term chronic renal disease. Your PTH will be super high, and your calcium will be high. Secondary hyperparathyroidism, it's the early stages of CKD. Your parathyroid is high, but your calcium is low. And primary hyperparathyroidism is high PTH and high calcium. So you'll have hypercalcemia, stones in your kidneys, groans, you have abdominal pains, and maybe even neuropsychiatric disturbances, so psychiatric overtones, constipation, flank pain. And if you have this going on for too long, you can actually have resorption of your bone to the point where you have cystic bone spaces filled with brown fibrous tissue. This is the osteoclasts and deposited hemosiderin from bleeds. And that's also due to high PTH, classically associated with primary hyperparathyroidism, but can be seen with the secondary phone. And renal osteodystrophy occurs when you have renal disease causing secondary and tertiary hyper-PTH. Other things could be familial hypocalciuric hypercalcemia. So you'll have high blood calcium, but a low calcium in the urine, and that's due to defective CASR calcium sensing receptors. So you'll need higher than normal calcium levels required to suppress PTH. And there's Nelson syndrome with Cushing's. So if you have an ACTH secreting pituitary adenoma that suddenly enlarges after bilateral adrenalectomy for refractory Cushing's disease, then the removal of the cortisol feedback leads to a burst of ACTH and basically causes, the hyperpigmentation, but also headaches, vision changes by temporal hemianopsia. And the treatment for that is pituitary radiation and surgical resection. Acromegaly, you want to check for IGF because the growth hormone will be high, and you'll you won't be able to suppress growth hormone following an oral glucose tolerance test, and you'll get an MRI to see the pituitary mass. Dwarfism is a defective growth hormone receptor, so you have low IGF, and growth hormone is trying to compensate, so it's elevated. You have diabetes insipidus, which is where you have a resistance to ADH for some reason. Either it's central and you're not releasing ADH, or you have normal high levels of ADH, but it's not working on your kidneys at the collecting tubules because of nephrogenic DI. And so that can be due to lithium, ADH antagonists like dimethylcycline, or it could be hereditary. And the way you do this differentiation between the two is a water deprivation test. And if you have some increase in concentration of your urine after initiating water deprivation with an ADH analog being administered, then that means your kidneys are able to respond to it, so it's probably central. But if you give ADH and your urine doesn't concentrate anymore than it was at the start of the water deprivation test, then you know it's nephrogenic, and it's something with the kidneys. The opposite of that is too much ADH, and then you get a euvolemic hyponatremia. SIADH can be from drugs like cyclophosphamide, pulmonary disease, cancers, ectopic ADH being released from small cell lung cancer, CNS disorders, or head trauma. Treatment for this is fluid restriction, that's first line, and then you can do ADH antagonists like the Vaptans or dimethylcycline. The opposite, again, with ADH, if it's central DI, diabetes insipidus, you would want to give desmopressin, which is a vasopressin analog. If you have a lack of pituitary hormones, you want to consider, is it something like empty sella syndrome, which is basically the compression of the pituitary. It can be associated with idiopathic intracranial hypertension or in obese women. You can have pituitary apoplexy, which is the hemorrhage of the pituitary gland, often with a pre-existing pituitary adenoma. Brain radiation, brain injury, or Sheehan syndrome, typically following postpartum bleeding. Pregnancy-induced pituitary growth leads to basically a susceptibility to hypoperfusion. And that presents with agalactorrhea, absent menstruation, amenorrhea, and cold intolerance. You can also have weird pituitary adenomas that are non-secreting, and craniopharyngiomas. Diabetes, differentiate between type 1, type 2. Type 1 will have DKA more often. They can also usually present more younger than type 2, and they'll have often they won't even have metabolic syndromes. They'll just be otherwise healthy, but they can have type 1 diabetes. DKA you want to treat with fluids and insulin. HHS you want to treat with fluids and then insulin. You might need to give K if it's less than 5.3, phos if it's less than 1, bicarb if pH is 6.9, dextrose once it's less than 200. Again, there's glucagonomas with the rash, diabetes, DVTs, depression. That's beta, or that's alpha cells that are interspersed. Then there's insulinomas, which are the beta. That's more central. Oh no, alpha is peripheral, sorry. The somatostenomas, these are released by the delta cells. These will have also diabetes, steatorrhea, gallstones, low acid. So that can also kind of overlap with VIPoma, which will also have low acid. Treatment is somatostatin analogs like octreotide. Carcinoid syndrome, that will lead to flushing, diarrhea, right-sided heart valve disease like tricuspid regurg, which is holosystolic, or even pulmonic stenosis. You can find urine 5-hydroxyindoleacetic acid, 5-HIA in the urine, There might even be niacin deficiency because niacin is used in the creation of all that serotonin. Markers for that is chromogranin A and synaptophysin. Treatment is surgical resection and somatostatin analogs like octreotide. So remember, octreotide can be used for somatostatinoma and carcinoid syndrome. ZE syndrome associated with MEN1 is too much gastrin. Gastrin will be released despite secretin stimulation test. This will be duodenal or gastric ulcers that are recurrent and refractory. MEN1 is pituitary, parathyroid, and pancreas. And then MEN2A, MEN2B is pheo and medullary. Then the only difference is MEN2A also has the parathyroid, and then MEN2B has the marfanoid mucosal neuromas. And then treatment, medication. So remember, NPH acts a little longer. So if you give NPH in the morning, it acts on dinner time glucose. GLP-1 analogs like zenatide and liraglutide, those decrease glucagon and delay gastric emptying. So they increase satiety. Side effect is pancreatitis. Amylin similarly decreases glucagon release. Metformin stops hepatic gluconeogenesis. Can cause lactic acidosis with renal insufficiency, B12 deficiency. The glitinides or glinides, these basically close the potassium channels in the pancreatic beta cell membrane, so you have insulin being released. The DPP4 inhibitors, these inhibit the enzyme that activates GLP-1. These are the gliptins. These also decrease glucagon release. Thiazolidine diones or glitazones, they bind PPAR gamma. These usually aren't used as much anymore because of their off-target effects on salt retention and worsening of edema and heart failure. But remember that PPAR gamma has an interesting association with follicular carcinoma of the thyroid. Flazins inhibit SGLT2, so they block reabsorption of glucose in the proximal convoluted tubule. This can sometimes lead to euglycemic decay. Empagliflozin actually also has a mortality benefit in heart disease, heart failure. Acarbose or miglitol, these inhibit brush border alpha glucosidases, so they impair carbohydrate hydrolysis and glucose absorption in the GI. This can lead to GI upset. Thiamides are like PTU and methimazole. They act to stop the oxidation of iodine, organification and coupling, decrease peripheral conversion. Levothyroxine is just thyroid hormone replacement. ADH antagonists in the setting of SIDH are Vaptans. If you have DI, you want ADH, so use an analog to vasopressin like desmopressin. Oxytocin can contract down the uterus during uterine atony and bleeding, or you can use it in labor induction. Also promotes milk letdown and bonding. Somatostatin octreotide used for acromegaly, carcinoid syndrome, gastrinoma, glucagonomas, and esophageal varices. There's at least 5 different things for octreotide, somatostatin. Demeclocycline used for SIADH, just like the Vaptans. Fludrocortisone for adrenal insufficiency. Cinacalcet for lowering calcium levels. Sevelamer for lowering phosphate levels.